Good evening, everyone. I can see now more than 1,000 already joined us. In 1 or 2 minutes, we will start our webinar for today. Just we will wait like 30 seconds or so to upload the speakers. Now we have the attendees. Now we have participants reaching 1,800. Try to share my screen. So we have 2,000 now. I think we can start. So good evening, everyone, and thank you for joining our last MENA Forum of Challenge Hematology series. This is done every, I will put the slide. This is done the last Monday of each month, and we started this forum 7 September, and today is the last session. The topics was covering important topics in hematology, and today we will cover the myelofibrosis, which is one of the myeloproliferative disorder problem, which is common, and there is a challenge in many aspects. We are very glad to have distinguished speakers with us tonight. First speaker is Dr. Sergio Verstovsek from MD Anderson. Dr. Verstovsek is a well-known speaker in myelofibrosis and myeloproliferative disorder. He will speak today about the personalized management of myelofibrosis in 2020. There is many new things we're looking forward to hear from our speakers. Please don't forget for all the participants to put their questions in the Q&A section. We will filter it, and then I will ask your questions. We will speak tonight also about the challenge in clinical challenge and in the diagnostic challenge. Please, Dr. Sergio, without further delay, please, I will stop share and you can share your presentation.
Very nice to have me today on a panel. Thank you very much. I appreciate that. Can you see my slides?
Yes, we can.
Okay, and you can hear me well. So again, a big pleasure and honor to join today. A wonderful event and amazing number of participants. Hopefully my contribution as one of the three panelists will be useful to your everyday practice. It is really a personalized management of myelofibrosis that I will project how I look at that. And perhaps in the Q&A later on, I can learn from your experience, from your questions in particular. So I have about 25 minutes for my slides, and not to spend too much time in introduction, let's go directly into the disease course and complications. First, to make sure that we understand that the early pre-fibrotic myelofibrosis, which was introduced to us in 2016 in WHO classification of hematological neoplasms, is in large part different than fibrotic myelofibrosis or post-ET, post-PV myelofibrosis, the one that we usually think about when we talk about myelofibrosis. I want to spend 2 minutes on the early pre-fibrotic myelofibrosis, which is on the left side of this slide. This is the short-term vascular events are the problem, and we manage as ET because typical survival is about about 15 years. And I want to exemplify this with 2 additional slides because there is a lot of confusion. What is actually early prefibrotic myelofibrosis and what is the management style for these patients? And then we're going to move to what we see here: overt myelofibrosis, fibrotic myelofibrosis with short life expectancy, 5 to 7 years, and all these problems that we can see with constitutional symptoms, with organomegaly, with cytopenias, with leukemic transformation in a quarter of the patients, and bad quality of life. So this will be the topic today. So starting with early prefibrotic myelofibrosis, 2 slides. This is not so aggressive neoplasm. Remember how we came to recognize this entity. 2011, 10 years ago, major paper in Journal of Clinical Oncology. Look at the left side of the slide. The patients that were supposed to have essential thrombocythemia in the experts academic centers throughout Europe were reanalyzed, and about 20% of them were said, no, you have early prefibrotic myelofibrosis, and the outcome is different. What is the difference? For ET is close to normal, about 20 years. For 65-year-old, 70-year-old patient, this is typical age, that's about normal. For prefibrotic myelofibrosis, it on average, the life expectancy is 15 years. 15 years. What's the risk of transformation to fibrotic myelofibrosis? Right upper panel, prefibrotic myelofibrosis, 15% after 15 years. And what's the risk of transformation to acute myeloleukemia? About 10% after 15 years. So when I see patients with prefibrotic myelofibrosis, I tell them, look, it is not so aggressive because the risk of dying is delayed. It's not 5 to 7 years. It's 15 years and 15% risk of progression to fibrotic and 10% risk progression to AML after 15 years. So remember that 15 years or 15 as a number, which is useful across the board. So what's the management style? If most of the people were carved out of what we used to call ET, then of course it's mimicking ET, and we need to worry about bleeding and thrombosis. Only minority of the patients will develop over time those symptoms of progressive fibrosis and have symptoms and shorter life expectancy. So we basically treat patients with prefibrotic myelofibrosis the same way we treat ET patients, applying the same prognostic scoring systems for thrombosis, and try to decrease this thrombotic risk. Okay, moving on to prognostic models for fibrotic myelofibrosis. Of course, they can be applied to prefibrotic myelofibrosis, but again, people will be by and large low risk or intermediate one. This is a classic prognostic models for myelofibrosis. I'm not going to go through them. Just to remind everybody that we started with IPSS, developed DIPSS that has the same 5 factors. None of these are molecular or cytogenetics. In the DIPSS, anemia has more weight. And then DIPSS Plus introduced the cytogenetics, platelets, and transfusion. Not to remember all of those, just to remind everybody, why are we prognosticating? To identify the patients that have a life expectancy less than 5 years. You see this in a table. By any of these 3 prognostic scoring systems, intermediate 2 and high risk are those that have a life expectancy less than 5 years, and they should be referred to the transplant. That's the ultimate goal of the prognostication, not much of anything else, right? It shouldn't be that we prescribe pills or IV medications or sub-Q injections based on risk of dying. It is the primary reason for prognostication to refer to the transplant. And even then, there is a lot of confusion. Our Spanish colleagues published this a few years ago, comparing the performance of IPSS in the blue colors to DIPSS in the middle and DIPSS Plus in the right part. This is the separation of the patients, the same close to 500 myelofibrosis patients in the Spanish registry by different prognostic scoring systems at the same time. And I want to give you one example how this is unreliable, actually. Look at here in the blue color, intermediate 2 risk patients in the upper panel of the blue. If 1 month later you see the same patient and now you apply DIPSS, only about 40% of the patients will stay intermediate 2. 61% will be downgraded to intermediate 1. Just 1 month later, you say prognostic scoring system that I use at the time of diagnosis, IPSS, put the patient in intermediate 2, and then a little bit later, it's intermediate 1 with completely different prognostic outlook. So That gives you the good sense how the seriousness of these prognostic scoring systems, and everything that we do needs to be taken a little bit with a grain of salt. It's not black and white. And of course, molecular information contributes significantly to outcome. In the upper part of the slides, we know that the driver mutations have an impact. Reticulum positive patients have the best outcome, and triple negative patients have the worst outcome in the upper part of the slide. And many of us now do NGS testing in everyday practice. Here we do this automatically in everybody, and we can do this extensive testing in about 82 different genes to identify high molecular risk features that are listed in the lower part of the slides, which further can divide the patients in a different way with the new prognostic scoring systems. So what about these new prognostic scoring systems? Here is one example: MIPSS 70, 70 plus, version 2, GIPSS. There are so many of them, and they are complicated. Look at this one. This is MIPSS 70 plus. You have to know the driver mutation status because it includes reticulum type 1 absence, then high molecular risk and a number of high molecular risk mutations and the karyotype. We don't even may not have all this information, and if you do, you need to go online to put this on this website to calculate, because it's not that easy, right? It's not that easy. So the practical question is, when do I use this more perhaps specific, perhaps more accurate prognostic scoring systems? Should I be testing for all of this? The cost is associated. I would say that I am perhaps old-fashioned. I use simplicity, IPSS, DIPSS, and then if I have an issue with the intermediate risk patients, then I plug in the molecular information, karyotypic information, and say, is that patient, which is perhaps intermediate 1 with IPSS or DIPSS, is that patient then going to be sent to the transplant sooner because of bad karyotype or bad molecular? Certainly, I don't see a reason to test everybody with all this testing. If you are high risk by IPSS, highly unlikely you're going to be low risk by any other prognostic scoring system. So we need to put this in perspective for everyday management. Are we prognosticating at all? That's the bottom line of what I have said so far. Unfortunately, it doesn't appear to be the case. This is an unpublished paper as of yet. Almost 500 patient charts were analyzed here in the United States. A third of them did not receive a risk categorization at diagnosis at all. And I can understand that, okay? If the patient is older, not a transplant candidate, why would you prognosticate? It's not a transplant candidate, doesn't really need to be done. However, the problem is next bullet. Of those who did receive a categorization at diagnosis in terms of prognosis, half were just based on clinical judgment of the patient, of the doctor. The doctor comes in a room and says, I think you're going to do well. That's what I'm talking about. If that is done this way, then we are over optimistic. Look at the last bullet. Risk categorization by the physician's clinical judgment without using this information that we have. Most of the patients were called as a good prognosis. It's over optimistic view of the situation that we try to project without utilizing actually the information that is handed to us. So let's be a little bit more cautious about properly prognosticating and utilizing this information properly. Let's move on to therapy. Once we are done with prognostication, the referral to transplant, yes or no, then we say what's wrong. So the clinical needs are here on the left side, the slide that I typically use quite often. And we're going to talk a little bit more about constitutional symptoms, because that appears to be a major problem in identifying them. And we know that Roxolitania is here for symptomatic splenomegaly, for the symptoms, and also it can provide some survival advantage, which I'm going to explain a little bit more in detail. The much more information is coming up now on the issue of extending the life for a few years of patients with therapy with Roxolitania. Let's talk about the quality of life. What's the best way to objectivize the quality of life? Application of MPN-10 is something that we highly encourage everybody to do. It's part of the NCCN guidelines, United States guidelines, how to manage patients. It's not that complicated to do it. 10 questions, each from 0 to 10. You have then 100 points that patient can have. And you can judge the quality of life very well with this and utilize it prospectively to see what's going to happen with the patients if you don't treat, or even if you treat, whether it's getting better. The problem is that we don't utilize this questionnaire at all, and we again are overly optimistic in assessing the quality of life. This is one of the studies done by our German colleagues, published several years ago, saying that many patients that are observed have symptoms. Many, almost a quarter of the patients that are just observed have a moderate symptom burden. And despite the significant symptom burden in some untreated patients, many are not being treated because the physician doesn't have that very good insight into the quality of life of the patients. And that's why we would like the questionnaire to be used quite often. All right, how bad the symptoms need to be to start the therapy? If the scale is from 0 to 100, 10 questions, each from 0 to 10, 100 is the total, how bad the symptoms need to be? I pulled this slide. This is from a study which is for a second line after Ruxolitinib, a study between the drug called momelotinib and danazol for approval in the second line after Ruxolitinib for symptomatic patients. The primary goal is to improve the quality of life. The secondary is to improve the anemia. The FDA agreed that if the symptoms are 10 or more on a scale from 0 to 100, if it's 10 or more, then the patient is sick enough for investigational study. So perhaps this is something to utilize as the information when we think how bad the symptoms need to be. It says 10 or more on scale from 0 to 100. You can go on investigational drug even. Moving on to what to expect from Ruxolitinib. We know that, right? So the spleen response, this is the waterfall. Each vertical line is one patient's spleen going down. Most of the patients, 97% of the patients have a spleen response. Only 3% are primary refractory. I would usually say 5% of the patients don't benefit enough. I would like everybody to benefit much more, but it's satisfying to say 97 have some degree of improvement. The point of this slide is actually a blue color. People always say, how about hydroxyurea? Well, hydroxyurea was part of the best available therapy. Almost all the patients, great majority of the patients were treated with hydroxyurea as a control arm. Well, it didn't work well. So there is no comparison between the ruxolitinib and hydroxyurea in terms of controlling the signs and symptoms of the disease. Spleen and symptoms are much better controlled with ruxolitinib, and you see photos of one of my patients in that regard. Therefore, we can easily say that ruxolitinib is preferred medication for symptoms in the spleen, and Hydrea is for control of progressive leukocytosis or thrombocytosis as a cytoreductive therapy. Over the last few years, there is much more information coming out from many different sources that earlier intervention matters. This is a study that you may be very familiar with, a JUMP study, 2,200 patients in many countries around the globe. Anybody who had a spleen or symptoms were allowed to participate, including patients with low intermediate 1 risk in red color, intermediate 2 in gray, and high risk in blue. What I'm showing here is over time from left to right, week 4 to week 72, a spleen response based on a risk of dying, which I don't like much, but it's very useful for what the point I want to make. You see always the red color is better, right? Better spleen response in a lower risk patients because they can receive the higher dose. They can receive the higher dose because these patients have less anemia and thrombocytopenia. Those are the parameters that affect the dose. So better the dose, better the spleen response. This is not the only source of that particular connection. Many, many papers have been published so far saying the higher the dose, the better the spleen response. This is another one from the Italian experience, 20 milligrams twice a day, much better than 15, much better than 5 in terms of achieving that response in the spleen. And we know that from the reanalysis of the comfort studies that led to ruxolitinib approval, this is on the left side, clear connection between the dose, the higher the dose, the better the spleen response. This is not so for this quality of life improvement. For quality of life improvement, which is on the right side, 10 milligrams twice a day is good enough if that's your goal. But if you want to decrease the spleen as much as possible, you need to go up. So my usual take is avoid starting with low dose. If you start with low, escalate quickly to a maximum safe dose within first 6 months. Doses less than 10 milligrams twice a day, like 5 milligrams twice a day, do not really work very well. So there is one paper that summarizes everything that I said so far based on the data from 408 patients. This is Palandri's paper from 2017. that clearly, based on the data in that paper, so if you want one source that tells you all of this together in one paper, this is the paper. Influence of disease stage and quality of response. Time interval between diagnosis and start of ruxolitinib. If it's very long, people will have a bigger spleen, high risk of dying, more anemia, more platelets, lower platelets, and therefore earlier intervention matter. And then the lower part of the slide explains the influence of the dose. Earlier disease patients may tolerate higher dose, and higher dose is affecting the spleen much more. Higher dose, better spleen response. Why am I so much pushing that information about the spleen response? Because I want patients to live longer. Let's talk about longevity. 7 years difference between these two photos at the time of presentation to my clinic on the left, and 7 years later, the same person. We know that information about the prolongation of life from the comfort studies, a lot of argument about this. This is the summary. The orange color is ruxolitinib treated patients in comfort studies. In the yellow color is the patients in a control arm, where majority cross over to ruxolitinib. Despite the crossover, there is a 1.5 year difference in survival. And the green color are patients that did not cross at all, right? So 3 years difference between green and orange. However, this is not the only information about survival benefit. This is from Medicare claim database, very large federal database here in the United States. We looked at this database. You have a very large number of patients and said, is there any influence of exposure to ruxolitinib in terms of prolonging life of the patients? Just a simple question in the federal database. Ruxolitinib exposed and ruxolitinib unexposed patients. Biases are possible, but simple question is answered, yes, exposure to ruxolitinib makes people live longer. Why would they live longer? They have a better albumin, so protein goes up, cholesterol goes up, body weight goes up, performance go up, and renal function improves. Remember, this is infiltrative disease. Infiltration in the liver, infiltration in the lungs, infiltration in the kidney. This is a paper from 2019. Dr. Strati published this. This is improvement in a kidney function on a ruxolitinib, which is tied on the right side to improvement in a failure-free survival. So people have better metabolism, better performance status, better kidney function. That's why people live longer. And earlier intervention again matters. If we go back to the analysis of comfort studies, we have here in orange color, the darker orange and younger, and the other color in a control arm. You see a much better difference in survival benefit for intermediate to risk group. See here, intermediate to risk group is much better than the high risk group. So earlier intervention will make a spleen smaller. The spleen is the major factor that makes people live longer. The smaller the spleen, the better survival. Analysis of the comfort studies, upper part, ruxolitinib, 10 to 25% decrease in the spleen, and then 25, 35, 35 to 50, and 50. The better the spleen response, longer the people live. That's one of the markers that I always aim for. I want them to feel much better, fine. I want to optimize my dose to get the spleen as small as possible during the first 6 months of the therapy, because each 10% reduction from baseline in spleen length at 6 months was associated in comfort studies with a 9% reduction in the risk of death. So that is the goal that we should actually aim for, not just the quality of life, but the spleen and the survival. The same was seen in a community practice from Northern Italy. Responders by palpation, you don't really need to have MRI. Responders live longer. The smaller the spleen, the longer the life in a community setting, right? And then the issue why we cannot really simply approach that issue here. The issue here is the platelets go low and the red blood cell count goes low, right? So there are limitations in the dosing of ruxolitinib. That's why I'm advocating early intervention, because we have less issue with thrombocytopenia or anemia at the beginning, right? People are less anemic or thrombocytopenic at the beginning. You need to adjust the dose based on platelet numbers. We know that, right? We know that very well. But let's talk about anemia here. You see the hemoglobin goes down on ruxolitinib, and then there is a rebound. Part of it is dose adjustments. There are no guidelines how to adjust the dose. You can adjust the dose on your own, your medical judgment, but then there is a rebound even in those that do not dose adjust, even in those that do not dose adjust, because and I can really explain it, that's the problem, there is the natural rebound in red blood cell count. Part of it is also perhaps because we add, not in studies, but we do add otherwise the anemia drug on top of ruxolitinib to counteract this anemia problem. The anemia problem is the one that usually affects the delivery of ruxolitinib. With the platelets, we are less concerned. That doesn't happen too often, and we know what to do. With anemia, a lot of uncertainty. Count on the rebound during the first 6 months, even without those adjustments. Add the anemia drug to counteract it, and don't really dose adjust or lower the dose unless absolutely necessary. So how to manage these early onset cytopenias, right? Decrease those or interrupt, which I would not advise at all, but it needs to be said that sometimes that is absolutely necessary. Decrease the dose as per your medical judgment. Look at the trajectory of the decrease of the blood cell count, seriousness for particular patients, and of course, give occasional transfusions if necessary. Monitor pressures more closely. Add erythropoietin stimulating agents or danazole. It's low probability of success, but it may help actually, or consider adding prednisone or thalidomide. Thalidomide in particular, 50 milligrams daily, appears to be something that can be tolerated very well on top of ruxolitinib and can increase the red blood cell count and platelets as well. And I'm talking about ongoing clinical study that shows that information to us in public domain. So that was already reported a couple of times. Low dose thalidomide appears to be beneficial, and if you can use it in community practice, try to do that on top of ruxolitinib. If there is still a concern about optimizing the dose or starting ruxolitinib at the optimal dose from the beginning, there is alternative dosing regimen. This has not been published as a paper as of yet, but it is getting traction, and many people are looking at this and saying, why don't I do that? What I'm talking about, starting at 10 milligrams twice a day, and then going up from 10 to 15 to 20 to 25, all within first 6 months. I do this sometimes in elderly patients in particular. I go with the lower, but then in a month or two, I go to from 10 to 15, and then again in a month or two, from 15 to 20, trying to optimize the dose to get that spleen under control. In this particular study from Europe, Dr. Cervantes reported 56% response rate by palpation. This is all community-based. 56% of the patients having at least 50% reduction in the spleen with this alternative dosing schedule, going from low to high, from 10, 15 to 20 during the first 6 months. With that, it's much safer. This is a hemoglobin level over time, much less of anemia because you are more cautious and you go up if you need. And so this is something that perhaps is going to be developed much more and endorsed much more in guidelines. But this is something that may offset that worry about starting with a higher dose and then needing transfusions or dose adjustments. Consider this in your own practice. So my tips on using ruxolitinib is that it's certainly indicated for control of the splenomegaly and symptoms, regardless of a risk of dying. That should not be connected to each other. And anemia, although a major problem, is not really contraindication. It does not affect the benefits of ruxolitinib, and I try to avoid prophylactic underdosing with ruxolitinib in terms of leaving patients on a low dose. If I can go up, I go to the maximum tolerated dose early on to get that spleen under control, to get that survival benefit from higher dose of the ruxolitinib with a higher or better control of that splenomegaly. So moving from the quality of life to the spleen control as much as possible to the extension of life. Avoid abrupt interruption of ruxolitinib. We know that very well in responding patients because symptoms come back within 7 to 10 days. Be aware of a rare possibility of opportunistic infections. We know that as well, nothing new. And also monitor for skin cancer, which was seen in patients previously treated for a long time with hydroxyurea. These are PV patients typically here in the United States because hydroxyurea on its own has a higher risk of causing squamous cell carcinoma of the skin. And it seems that ruxolitinib in this particular setting can enhance that risk. But this is very, very rare actually. So one more time, let's move from quality of life benefit to the spleen benefit and optimize the spleen benefit for patients to live longer. And this is another one of my patients from 2008, still alive and well. All these years later, with the control of the disease, he's not in CR. We don't have CRs and PRs. let's move on to higher bar and aim for prolongation of life with optimal management in 2021. So I thank you so much for your attention. I hope this was useful for your own practice. Certainly these slides are to be shared. And this is my email. Please send me any questions about any case in the future. I'm always happy to help with the patient management. So I'm going to stop here and stop share, and we'll have a nice discussion. Thank you so much.
Thank you very much, Prof. Sergio. It was really nice and goes to the clinical part where all hematologists have a challenge when you want to start what's the dose, and I like also your tips at the end. There is many questions, so if you please allow me to keep the questions till the end, we will have the honor to keep you till the end if you not mind, please.
Yeah.
Now I will go to Dr. Ahmed Al-Saeed, who's a deputy chairman of Princess Noura Oncology Center in National Guard, Jeddah. Dr. Ahmed Saeed is a well-known hematologist, and I like his presentation since I was a fellow. This does not mean that Dr. Ahmed is too older, or no, he's very young, and I like always his presentation really because it's also focused. Dr. Saeed today will focus on the BMT or bone marrow transplant challenge in clinical aspect who are eligible. And please, Dr. Ahmed, proceed.
Assalamu alaikum. Thank you, Dr. Marwan, and thank you for SSBD for the invitation. It's difficult to talk after Dr. Sardan, but I'll try my best. So my task is to go for some clinical challenges, BMT focus in myelofibrosis. As you know, allogenic transplant currently remains the only potentially curative treatment for myelofibrosis. Give me a second. And it is the only treatment tool in myelofibrosis that is associated with evidence of molecular remission and complete resolution of bone marrow fibrosis. And over time, many trials showed a long-term survival and possible cure for myelofibrosis post-allogenic transplant, with an overall survival of about 30 to 60%, but the non-relapse mortality is as high as up to 43%. So this was reflected on the practice, and there is over years increasing number of transplant for myelofibrosis. This was shown in Europe with the EBMT data, and also in the US, where the number of MPN transplant, including myelofibrosis, increased over the last few years. And this is why, because we have advantage of the transplant. There is it's a curative, there is a long-term survival. We have a long experience, and there is clear decreased risk of progression and AML transformation for myelofibrosis. But unfortunately, there are some disadvantages. Transplant is not for every patient. Not every patient is fit. Not every patient has a donor, and not every patient benefits from transplant. It is an intensive treatment and is associated with complications like GVHD, graft failure, immune deficiencies. And unfortunately, there is no prospective randomized trial comparing transplant to non-transplant. So this brings us to challenges of transplant in myelofibrosis, which I think this includes many issues. Which patients is indicated for transplant? And of those patients, which patient can benefit from transplant? What is the best donor? What about the pre-transplant treatment, especially the role of standard of care now, Roxolitania? And is there any role for splenectomy pre-transplant? And what is the best conditioning regimen for transplant if we will go for transplant? So I will go briefly over these challenges in the coming 10-15 minutes. Starting which myelofibrosis patients needs transplant, or what are the indication of transplant in myelofibrosis. So prognostic stratification, as mentioned by Dr. Serg, is the current key clinical decision-making factors to indicate the transplant based on the short survival seen in the high-risk groups. There are multiple prognostic scores, as mentioned earlier. So which one to use to go for a transplant? This study is published by Dr. Krogan in 2015, which showed the impact of allogenic transplant in myelofibrosis patients less than 65 years. This is a retrospective study, so stratified patients based on DIPSS to see to evaluate the outcome on 190 patients who received transplant versus 248 patients who received the transplant. And what they found that the survival of high risk, intermediate to and high risk patients favored the use of the transplant with a statistical significance difference. For example, in a high risk patients, the 10-year survival is 27% in transplant compared to almost no patients in non-transplant. But the difference in low and intermediate risk was in favor of non-transplant. One important point for this study is no patients were treated with Roxolitania, which is the daily practice today. Another larger multi-center retrospective studies published last year from CIPMTR, where they studied the overall survival of myelofibrosis patients, compared 551 patients who were transplanted to almost 1,400 patients who were not transplanted. And based on DIPSS, what they found, they confirmed that the patients with intermediate to and high risk, the transplant is superior. The low risk patients, the non-transplant is superior. And some patients of intermediate one, they might benefit from the transplant. One important point of this study, shown in this study, is that the benefit of transplant will take time to be seen. And if you see the lines they crossed, and for example, in intermediate one after 6 years, in low risk patient after 9 years or 10 years, but it's crossed early in the intermediate one and high risk patients. So what is the impact of molecular genetics stratification on the outcome of allogenic transplant in myelofibrosis? As shown by Dr. Serge, that there are multiple scoring systems now involving genetic factors. So recently published multiple study addressing this issue of impact of molecular genetics on the outcome of myelofibrosis. And the conclusion from this study is that the molecular mutation might have an impact on the outcome after allogenic stem cell transplant. For example, the patients with CAL reticulum mutated have a significant improved outcome after transplant, while the patients with ACXL1 and IDH2 mutation have a poor outcome. But what can we say that we need a further study to validate this recommendation? So what are the indications for transplant in myelofibrosis now? These are the revised recommendation from ELN and EBMT, where they mention that transplant is indicated in patients less than 70 years who have intermediate 2 or a high risk disease. It's indicated intermediate risk 1 in a patient less than 65 who has a refractory transfusion-dependent anemia, who had a blast more than 2% in the peripheral blood, or who has adverse cytogenetics, while the transplant is not indicated in a low-risk disease. Now, if you have a patient who has indication for transplant, the next question is who might benefit from the transplant, or how can we best select patients for a transplant? This was clarified or studied in a recently published paper where they aim to develop a prognostic score to determine the prognosis after transplantation. 361 patients were divided into 2 cohorts. training cohort of 200 patients and validation cohort of around 150 patients. And they used what is called MTSS, or Myelofibrosis Transplant Scoring System, and the multivariate analysis on survival, and identified 7 factors to predict the outcome of the transplant, including age, platelets count, white cell count, performance status, driver mutation, additional mutation, and the type of donors. And they categorized patients into low risk, intermediate risk, high risk, and very high risk. And they found that the patients who had low risk or intermediate, their outcome, the survival is 90 and 77%, while the patients who have very high risk, their survival post-transplant is only 1/3 of the patients. Who is the best donor to use for transplant in myelofibrosis? So this was addressed early, long time ago, and this paper in 2009 from the EBMT, prospective multi-center phase 2 trial, and it showed multiple factors affecting the outcome. One of the factors is the type of the donor, where the mismatch unrelated donor is significantly inferior to match-related, HLA match-related donor, or HLA match unrelated donor. Another study by DRC in 2014, where they evaluated 66 patients, 32 patients for sibling donor and 34 for unrelated donor, and they used the RIC flow melphalan for related donor, and they added ATG for unrelated group, and with a median follow-up of 25 months, they found that the overall survival is 75% in a sibling group, and it's only 32% in the unrelated group, with a median overall survival not reached in the sibling groups, and it's only 6 months in the unrelated group, and the non-relapse mortality was significantly high in unrelated group. Engraftment was also in favor of sibling group, and the MUD associated with 24% primary graft failure and 12% of secondary graft failure. So again, it showed the difference between related and unrelated donors. Now, what about haplotransplant in myelofibrosis? As you know, haplotransplant is increasing in many hematological malignancies. So a recent paper from Chronic Malignancy Working Party of the EBMT, where retrospective review of 56 patients, the median age was 57 years, transplanted from family mismatched donors. The stem cell were bone marrow in 66% and peripheral blood in the rest of the patients, and 70% of the patients had myeloablative conditioning. So what they found that the overall survival, 1 and 2 years, was between 60 and 56%. The progression-free survival was, this is the progression-free survival in, I'm sorry, I think go back.
Yeah, we can see your slides now, Dr. Ahmed.
Yeah, I don't know what's wrong.
Move here,
Okay.
in the arrow here.
Yeah, so this is the progression-free survival at 1 and 2 years, around 50 and 60 and 40%. And relapse at 2 years is about 19%. But if you see the non-relapse mortality at 2 years is around 40%. The acute GVHD was seen in about 28% at 100 days, and the chronic GVHD was seen at about 45% at 1 year. So donor selection remains crucial for myelofibrosis, and it has an impact on treatment outcome. Transplant from alternative donors is associated with high non-relapse mortality, mostly from graft failure and GVHD. Mismatch a related donor is associated with poor outcome. And in contrast to other hematological malignancies, haplotransplant with post-transplant cyclo in myelofibrosis is associated with less favorable outcome. So the best donor is the full match, is a full HLA match donor. What is the impact of pre-transplant Roxolitania? As mentioned, Roxolitania is the standard of care for most of the patients. Roxolitania could be associated with decrease in spleen size, decrease in the general symptoms, and improve the performance status, decrease in the inflammatory cytokines. So this collaborative multi-center retrospective studies from Canada, US, and UK examined the effect on Roxolitania, use of Roxolitania pre-transplant on the transplant outcome. And it found that the patient who has clinical improvement to Roxolitania is associated with better overall survival, less non-relapse mortality, and less relapse compared to the patients with advanced stage or with less response. So positive impact on Roxolitania used to the outcome of the transplant. Another study from the EBMT retrospective study in almost 3,000 patients, 400 patients received Roxolitania before transplant. And in these patients, it was found that there is a tendency to reduce post-transplant mortality. Roxolitania is not associated with risk of graft failure or GVHD or relapse. And there was no impact on non-relapse mortality. So we could say the impact of pre-transplant Roxolitania, that use of JAK2 inhibitors prior to transplant has no adverse impact on the outcome. Continuation of JAK2 inhibitors close to the start of conditioning is recommended, and usually we can use it until 7 days before the conditioning regimen. Patients undergoing transplant when responding to the JAK2 inhibitors or Roxolitania had encouraging outcome. And myelofibrosis patients undergoing allotransplant at time of maximal response to Roxolitania, they have better survival than those who lost their response. What about the use of splenectomy pre-transplant? This is from EBMT registry, around 1,200 patients transplanted between 200 and 217. The splenectomy was done in about 200 patients. And one notice observation is that number is decreasing over time. So splenectomy was associated with less non-relapse mortality, but it is associated with increased risk of relapse. And there was no significant impact on survival. Last point is, what are the best conditioning regimens? So the optimal conditioning intensity for myelofibrosis allotransplant has not been compared prospectively. Historically, myeloablative conditioning is associated with significant toxicity, and REC transplant can extend the potential of transplant option for older patients. And for younger individual, maybe the myeloablative is better than REC. This study from the, again, chronic malignancy working party of the BMT, where they evaluated the myeloablative and reduced intensity conditioning transplant in myelofibrosis. This is a retrospective study where they examined, or they reviewed about 800 patients who received myeloablative compared to more than 2,000, compared to 1,500 patients who received reduced intensity. And what they found that there was no difference in the 5-year overall survival between MAC and REC. There was also no significant difference regarding the incidence of relapse. Also, there is a trend that more relapse with REC, and there was no difference incidence in the non-relapse mortality. So the conclusion from this study is that to use myeloablative conditioning for younger fit patients, because of the trend, less relapse and significant reduction in GVHD and relapse-free survival, and REC for older, less fit patients. The limitations of this study is this is a registry-based retrospective study, and it included a lot of heterogeneity for the patient. So with this, I come to the conclusion of some challenges of BMT in myelofibrosis, and thank you for that.
Thank you, Dr. Ahmed, for your presentation. And you focus on all the challenges that we face in a daily base. And now, last but not the least, Dr. Alia Al-Faraidi, head section of hematopathology in King Saud University, King Khalid University Hospital. Dr. Alia will give us the challenge from the diagnosis part. Dr. Alia is a well-known colleague in hematopathology, and she will talk about the challenge as well as the update in the criteria of the WHO. Please, Dr. Alia, go ahead.
Assalamu alaikum. Is my voice clear?
Alaikum salam, very clear. Alaikum salam.
Okay, thank you, Dr. Marwan, for giving me this chance to present some challenges in the diagnosis of myelofibrosis. So I would like to start with this slide regarding the classification evolution of myeloproliferative neoplasms, since that prior to 2001, actually all myeloproliferative neoplasms were classified as chronic myeloproliferative disorders. However, in the mid of 2000s, with the discovery of many mutations underpinning the polycythemia vera, essential thrombocythemia, and primary myelofibrosis, the 2008 WHO classification adopted a new morphological classification and incorporated the JAK2 mutation as a formal major criteria for diagnosis of polycythemia vera, and changed the classification of chronic myeloproliferative disorder to myeloproliferative neoplasms, and it included 8 subtypes. However, this classification was subjected to some criticism with regard to the reproducibility and accuracy in the diagnosis of certain subtypes, and this was followed by the 2016 classification. Certain modification was done. As you can see here, the systemic mastocytosis was changed as it has its distinguished clinic pathological entity, and the recognition of calreticulin mutation also necessitated that these 3 drivers mutations to be one of the major criteria in essential thrombocythemia and primary myelofibrosis. In addition to that, the primary myelofibrosis showed this prodromer phase, which is very important in the hematopathological features and the prognosis impact, and it's given as the primary or early primary myelofibrosis. So further classification also, or further differences between the 2008 WHO classification for primary myelofibrosis. As you can see here, mainly it's in the minor criteria, which went to under modifications, in which that we required, initially in 2008, we required the 2 minor criteria, which it changed to be at least one of the minor criteria. And you can see here that the early or the pre-fibrotic stage or early primary myelofibrosis, the leukoerythroblastic picture was also changed to leukocytosis only more than 11. And actually this is given to those many cases who has a borderline leukoerythroblastic blood picture, who shows that very few blasts or nucleated RBCs in the peripheral blood. So as you can see here, the diagnostic criteria for primary myelofibrosis have altered over time due to fundamental histopathological changes features which have not been changed. And as a consequence, the various groups of patients who were initially or in the histological literature diagnosed as a pre-fibrotic myelofibrosis might differ according to the 2016 classification. There was an ongoing debate about the clinical criteria required for the diagnosis of the pre-myelofibrosis, which prompt the added the presence of clonal markers or abnormal markers, as well as exclusion of the reactive bone marrow fibrotic changes. And as I mentioned, that this revision replaced the leukoerythroblastosis into leukocytosis, and only minor criteria now is needed. Okay, so regarding the step-by-step diagnostic approach, we still believe that the diagnosis of primary myelofibrosis is one of the exclusion because of the lack of specific diagnostic markers, ruling out the other reactive or malignant conditions that can cause the secondary myelofibrosis is essential, And again, every histological diagnosis usually should be preceded by a careful history and physical examination. So regarding the CBC, as we can know the behavior of the myelofibrosis affecting the multipotent progenitor cells, so it can affect any cell type with unpredictable manner. So anemia, which is usually mild, present in most patients with the primary myelofibrosis, more than 60% having hemoglobin concentration less than 10. Leukocytes and platelet count can be low, normal, or can be high without reference to the spleen size. Actually, patients with the primary myelofibrosis and thrombocytosis reveal that major bleeding may be a relatively specific event as opposed to the WHO-confirmed essential thrombocythemia. And actually, this can be one of the pitfalls in diagnosis to start with the CBC, especially with those patients who presented with high platelet count. Here, as you can see, we can demonstrate the peripheral blood smear showing the teardrop cells, which are usually encountered during the overt stage of myelofibrosis. And you can see the leukoerythroblastic picture with many blasts and nucleated red cells. Regarding the bone marrow aspiration, it's useful for the assessment of the cell morphology and to exclude any dysplasia or iron stains for evaluation of ring sideroblasts, obtaining marrow cells for other tests such as cytogenetics and genetic mutational analysis. However, and also, of course, determination of the percentage of the blasts. However, due to extensive marrow fibrosis, most of the time you can yield a dry tab. Pre-treatment bone marrow core biopsy is necessary for both establish a correct diagnosis and as a baseline for follow-up examination. I'd like to share with you this scheme for recommendation of the proper histopathological investigations whenever we evaluate a trifine biopsy for myeloproliferative neoplasm. So the focus should be given to the evaluation of the megakaryopoiesis, which include the frequency, the size, distribution, the presence of atypia, and maturation defects. The presence of fibrosis, reticulin and collagen stains, age-matched cellularity, iron distribution, myeloblast description, either blast clusters and the percentage of the CD34 stain, evaluation of granulopoiesis and erythropoiesis as frequency and distribution. And this is, of course, very important when you diagnose the pre-fibrotic stage of primary myelofibrosis, where usually they are associated with the granulocytic proliferation and reduced erythropoiesis. Osteosclerosis, of course, it's important for the diagnosis of overt myelofibrosis. So here, as we can see, this morphological pattern or changes which happen in the myelofibrosis. As you can see here, regarding the size of the platelet of the megakaryocytes, they will demonstrate variable sizes. They tend to have dense clusters and around the bony trabeculae. So what are the challenges in diagnosis? Inter-observer variability in myeloproliferative neoplasm diagnosis has been demonstrated in several studies with an approximately 80% agreement rate. However, this is a challenge that both pathologists and hematologists need to be aware of. So it is essential to consider the quality and quantity of the bone marrow samples, adequate investigations, medical history within a multidisciplinary process for these cases. Here, I want to share with you this study regarding the impact of the minor criteria between the patients who were diagnosed as essential thrombocytosis and pre-myelofibrosis. So the aim of this study was to compare the relative frequency of the 2016 revised WHO minor criteria between the pre-myelofibrosis and essential thrombocytosis. So it has shown that in total 170 patients with the pre-myelofibrosis and 225 patients with ET were the inclusion, and it showed that the most frequently parameter which is associated with the pre-myelofibrosis was the high WBC count and the elevated LDH. However, there is 8.8% of the pre-primary myelofibrosis patients failed to show one of the selected clinical features required for this, in contrast to 52% of the essential thrombocythemia patients. So in conclusion, this data showed a high reproducibility of the newly proposed WHO-defined minor criteria in the pre-primary myelofibrosis, and it showed that while approximately 50% of essential thrombocythemia patients also show one or more minor criteria, accurate distinction between the two entities is only possible by following an integrated approach, including histomorphological diagnosis as well as minor criteria. So regarding the morphological diagnosis, there was a cohort study which reported that 16% of patients with an initial diagnosis of essential thrombocythemia had a diagnosis revised to an early or pre-fibrotic primary myelofibrosis after re-review of the trifine biopsies. So we said that they found that another study found that among 295 patients diagnosed with ET or pre-myelofibrotic patients, the consistency between the two groups of pathologists was 78%. So I want to share with you this study evaluated the prevalence of early pre-fibrotic myelofibrosis in patients who were previously diagnosed as ET. So in review, this led to a diagnosis of WHO defined ET in 30 cases, which 71% of these cases. However, 14% of the previously diagnosed essential thrombocythemia were re-evaluated as early pre-fibrotic myelofibrosis. So the contamination ratio of the early pre-fibrotic myelofibrosis in patients who were previously diagnosed as essential thrombocythemia is mainly dependent on the diagnostic baseline of each pathologist, with a frequency of 16% in one report and 27% in another report. However, in this study, 14% of patients were initially diagnosed with ET in this cohort study, a proportion which is comparable with the two previous studies. The clinical parameters that could help to distinguish these entities have been reported in the patients with early pre-fibrotic myelofibrosis, found to have a lower hemoglobin, high leukocyte count and platelet count, higher serum LDH values, and higher frequency of palpable splenomegaly compared with the patients with ET. This is just to consider the entities, and as you can see that there is no single pathognomonic feature can differentiate between essential thrombocythemia and primary myelofibrosis. However, the understanding of the characteristic features of involving the megakaryocytes primarily in the trifine biopsy will help or will be the key feature to differentiate between the two categories. Here we can have the standardized morphological features which can differentiate between the ET and early pre-fibrotic. With regard to the cellularity, the essential thrombocythemia will have no significant increase in the age-matched cellularity. This is in contrast to the primary myelofibrosis, where marked increase in age-matched cellularity is evident. Granulopoiesis and erythropoiesis will have no significant increase, while we have pronounced proliferation in the granulopoiesis and reduction in erythropoiesis precursors. The megakaryocytes, which is the most important to look for, is the prominent, large and giant, mature and hyperlobulated or deeply folded nuclei, and this will give the terminology of staghorn appearance. However, in contrast, in primary myelofibrosis, the dense or loose clustering is the frequent feature, with especially around the bony trabeculae, and it would show variable sizes showing hyperchromatic or hyperlobulated, cloud-like or balloon-like irregularity of the nuclei. And of course, they will have a defect in maturation between the cytoplasmic and nuclear ratio. Reticulum fibrosis will be very rare and minor or focal increase in essential thrombocythemia. However, there will be no significant increase in primary myelofibrosis. So with regard to the pitfalls in grading the fibrosis and collagen deposition and osteosclerosis, we have here the WHO classification or for semi-quantitative bone marrow fibrosis. This was very important in the 2017 WHO grading system, which incorporated this scoring scheme for collagen fibrosis and reticulin fibrosis. What are the pitfalls which we have to take care while we are evaluating the reticulum fibrosis? We have assurance of adequate core biopsy size, avoiding areas with significant crush artifacts, and ensuring appropriate section of the thickness. However, the thickness it might lead to overcalling of the reticulum fibrosis. Staining of another section is warranted in cases of observed overstaining or weak staining. This is just to demonstrate here the collagen fibrosis and the extent of osteosclerosis, which is usually seen during overt stages of myelofibrosis. Immunohistochemistry in which recently the prepared monoclonal antibodies that recognize the mutated CAL on the immunostaining with positive findings obtained for the cytoplasm of megakaryocytes of the bone marrow biopsy specimens in those patients with MPN not otherwise specified, or in essential thrombocythemia, or in primary myelofibrosis. So I want also to demonstrate some points regarding the myelofibrosis post-AT and post-PV myelofibrosis. So regarding this, with regard to the diagnosis of post-AT and post-PV, which the criteria remain unchanged since 2018, and are listed here. So we can say that since the preceding diagnosis of ET and primary or polycythemia vera is required, the base modification in the diagnostic criteria of these patients indirectly impact the secondary myelofibrosis diagnosis. Most notably is the lowering of the hemoglobin threshold for the diagnosis of polycythemia vera to less than more than 16.5 in men and 16 in females, which has brought to the diagnostic reallocation of patients for polycythemia vera. This is from one of our patients. For this patient, he was diagnosed as pre-fibrotic myelofibrosis. As you can see here with the immunostains, it can highlight all these dense clusters and variable sizes of megakaryocytes. And you can see this changes, or we call it a sepia, typically for the myelofibrotic megakaryocytes. This is another patient who was diagnosed as post-AT myelofibrosis, and again, it can show significant changes which are different from the essential thrombocythemia changes of megakaryocytes. I would like to share this slide also demonstrating how to differentiate between the primary reticulum fibrosis and secondary reticulum fibrosis. This is a patient who diagnosed to have Hodgkin lymphoma involving the bone marrow. And as you can see here, this meshwork or nesting pattern of the reticulin fibers, which usually different from the parallel bundles, which you can see in the primary myelofibrosis. Another pitfall in the differential diagnosis is regarding the chronic myelomonocytic leukemia. However, in the 2016 revised WHO classification, updates has added a minimum level of monocytosis to the diagnostic criteria of CMML, which require monocytosis to account for more than 10% of the white blood cell differential count. Adding this criteria will have the overall effect of decreasing the number of cases meeting the requirements for the diagnosis of chronic myelomonocytic leukemia, keeping in mind that CMML is a sign, or the monocytosis is a sign of progression in primary myelofibrosis. I'll spend this few slides regarding the molecular diagnostics, and as you can see here, the distribution between the myelofibrosis, polycythemia vera, and essential thrombocythemia, where a JAK2 mutation will represent more than 60% of cases of myelofibrosis, followed by the calreticulin mutations and MPL, and we have the triple negative mutations. This is a suggested scheme how to go further for molecular diagnosis following the anemia, splenomegaly, and elevated LDH and leukoerythroblastic blood picture, where you suspect primary myelofibrosis. Further bone marrow investigations will be starting with the JAK2 mainly, followed by calreticulin and MPL. So for the sake of time, in conclusion, the morphological bone marrow evaluation of Philadelphia negative MPN is heavily subjective, and the inclusion of calreticulin mutation to join the JAK2 and MPL as a classic driver mutations in the WHO diagnostic criteria may have driven practitioners away from the required bone marrow and morphological examination. Somatic and germline mutational data have revolutionized the understanding, classification, and the treatment of MPN in a way unlike any other fields in malignant hematology. And thank you for listening.
Thank you, Dr. Alia, for this review for the diagnostic challenge. And now, with the 3,400 participants, we'll go to question and answer and the discussion. And is Dr. Sergio with us? Serjan?
Yes.
Oh, nice. Okay, Doctor. So I will start. There's many questions, but I will start with you. A question from our colleague hematologist, Dr. Muhannad Ahmed. He said, what do you think about the TP53 mutation in a low risk or in the intermediate risk? Especially it's not included in the MIPSS 70. So what do you think of this mutation?
The P53 mutation is very rare in a chronic phase myelofibrosis. There was a first publication by Dr. Teferi and then by our group as well. It comes in very low percentages. If it is in percentages at all, it would be maybe 1%. And there are too few patients, therefore, to account in the larger database for its significance because it's just such a low number. It is much, much higher, as we know from New England Journal of Medicine paper from Dr. Kralowitz in Europe, that at the time of the transformation to acute myeloid leukemia, 20 to 25% of the patients may have a P53. Now, of course, the patients that are in a chronic phase and have that mutation identified, are they at a high risk or not? The prognostic scoring systems don't say so, but one can suspect that over time that can be the case. There is a need for a study that would be prospectively follow their allele burden, right? VAF of the P53. That would probably give us some answer. But at the moment, it's anecdotal finding, and we don't usually use it as a bad prognostic factor just because we don't have that information ready.
Thank you, doctor. And the other question for you, for failure of Roxolitania, if you want to use another agent, what's your preference? He put here two options, busulfan or cladribine. Any experience with those post like or failure of Roxolitania?
Between the two, I have never prescribed you busulfan, so the answer is obvious. Cladribine quite often.
He said, "Is the dose you use?" He wants also to know the dose. If
yeah.
You
so the but let's talk about this because there are different ways of failing, right? So the failing based on the progressive anemia or thrombocytopenia because the low platelets on its own are bad prognostic factor. Anemia, before we say enough of JAK inhibitor, let's do something else, we try to counteract the anemia by adding anemia drugs, as we said before. The patients that really eventually stop because of cytopenias don't have very good options. I would probably go back to thalidomide and prednisone or lenalidomide and prednisone for patients with low counts. Patients that are progressing with a big spleen, if they can tolerate add-on of hydroxyurea, right? If there is an opportunity because of blood cell count is not so low, I actually add a hydroxyurea to ruxolitinib for progressive splenomegaly if the quality of life is still improved with ruxolitinib. Why change, right? Basically, for me, a loss of response to ruxolitinib is when nothing is controlled at all, a complete loss of any possible benefit. If the blast go up, then you would add hypomethylation agents, right? The standard practice is to add Videsa or Dacogen when the blasts are above 10. There's a lot of discussion now whether we should be starting that when we have blasts between 5 and 10, like 7 or 8. You have progressive increase, right? Why wait for 10? Why not start at 8? Because we know that they will continue to get worse. The low-dose hypomethylation agents can be also used in the chronic phase when there is a loss. You remember we published 3 years or 4 years ago paper that combined ruxolitinib with the low dose azacitidine, 25 milligrams per square meter daily, which was add on to people after 3 or 6 months of ruxolitinib. But the same can be applied to people who are losing response, low dose hypomethylation agents. Cladribine is really used in people who are proliferating a lot, 0.5 milligram per kilogram, 5 days IV monthly, like you do for hairy cell leukemia. So between these two options, cladribine is the one, busulfan I haven't used, but hypomethylation agents come handy. Remember those.
And what about a new usual practice about prednisone in advance, like before the failure, before you are using a small dose of prednisone, 20 or so?
I don't like to use the prednisone forever. So if the patient is not feeling really well or a cytopenia settle in and I try danazole, 200 milligrams daily, or I try erythropoietin stimulating agents if it's possible, if the erythropoietin is low, not too often. prednisone, I use it for 3 months. I use 30 milligrams daily for 1 month, 20 milligrams daily for 1 month, and 10 for 1 month. Just 3 months and see what happens. 15 to 20% chance of anemia response, and obviously people feeling well. And of course,
this is in combination, doctor?
In combination.
Okay.
In combination. And of course, if you want to stop ruxolitinib, you always worry about rebound. Even when you don't think that there is a chance of a rebound, you may be sometimes fooled. So if you see the symptoms coming back, give the steroids during the tapering off of ruxolitinib. Don't stop cold turkey, or you have to restart ruxolitinib when the symptoms come back very badly.
Thank you, doctor. And question to Dr. Ahmed Saeed. What do you think of the role of Roxolitania maintenance after transplant?
So I think Roxolitania can be used in patients who develop GVHD, acute GVHD post-transplant, so you can use Roxolitania. But if patients did not respond to transplant, or patients had graft failure, or their outcome usually is poor, and I'm not sure if Roxolitania or other things can be helpful. Maybe Dr. Sardanti, if there is any recommendation in this setting, but as far as I know, to use it as a maintenance post-transplant is not there.
I agree with you. So there is no role as a prevention of a relapse because it's not specific for the mutation, right? It should not be used in patients that have ejector mutations, only in those. It can be used in anybody with the myelofibrosis. And you are absolutely right in your observation that after transplant, the outcome is so poor, hardly anybody is interested in anything anymore. Unfortunately, if the transplant doesn't work, people choose to go home.
I remember one study that say the ruxolitinib in the peri-transplant, before transplant, they mean mainly, which reduce the GVHD risk, and like Dr. Ahmed Saeed, what he mentioned, to keep it till the end, till really near the conditioning. A question to Dr. Ahmed. Now you mentioned about the splenectomy, and it's only 16% of those patients were splenectomized. In our hospital, the risk of thrombosis in that situation is more than 10%, and we now only refer a huge spleen only for transplant. My question, in those 200 patients, or the other patient that was not splenectomized, any more detail in the data that if their spleen was, the size was not that massive, or if the response maybe to Jakavi, or
yeah, I remember in this retrospective, they mentioned also in their comments that subgroup analysis, they found that those who had spleen more than 15 centimeters, they are the one who do poorly compared to those who have spleen less than 15 centimeters.
You put the cottage,
as mentioned in the studies, and
this is 15 by ultrasound, or
no,
below or below
I'm not sure, but I think since mentioned 15 centimeters, I think it's by radiology. But as noticed in the study is that it's the use of splenectomy is going down, and maybe the major part is due to more use of Roxolitania.
Yeah. What's your practice, Dr. MD Anderson? Are you removing all the spleen, the large spleen, or you only choose the one who is really massive?
Yeah, we choose only those that are really massive, but there is no real measurement. It's a judgment call of the transplant doctor who is in charge, and it's very, very rare. I would say just maybe 5 cases a year among the several hundred patients. So I would say that the splenectomy has a role in perhaps treating patients that are pancytopenic, do not respond to any therapies, and you remove the spleen to improve their blood cell count. We don't utilize it in pre-transplant setting. Our practice is similar to yours. We push the ruxolitinib, even to higher dose for a couple of months to get the spleen as small as possible, despite perhaps patient requiring transfusions, because patient will get to the transplant in 2 months. And we keep the ruxolitinib until the last day before the chemotherapy starts as pre-transplant chemotherapy. We just taper it for the last week or so, and the day before the chemo starts, we stop. But I should probably bring to discussion your view of keeping the ruxolitinib even during the transplant for a couple of weeks, right? There was a publication from Europe saying
Yes.
we should probably let it
5
be.
milligrams.
We really actually think about this, and it's being done without real study in case-by-case basis to see whether this will further reduce the complications after transplant, and it does not appear to be interfere with the engraftment. So a couple of weeks into the transplant with
With a
ruxolitinib.
small dose, 5 milligrams? Or?
Small dose, yeah, 5 or 10 milligrams.
During COVID, Roxolitania showed some protection from COVID in some study, if you remember. So it's good really for even HLH and the cytokine, some case series using it. Question to Dr. Alia from Abdulaziz Al-Sayrafi. He said, what does you mean by crush artifact?
Actually, this is, we usually see it in the refined biopsy when it's traumatized. Sometimes the edges will be crushed and it will give you like false impression there is reticulum fibrosis. So you have to differentiate between these crushed or traumatized areas and the genuine reticulum fibrosis.
My question to you, Dr. Alia, sometimes we refer a case of query like MPN and we not know if there is a pre-fibrotic, and sometimes they not do reticulin stain. The question, when the hematopathology should consider doing the reticulin, is it a standard in all MPN?
In our practice, usually it's a standard to do reticulin stains with any refined biopsy we got. So reticulin, especially for MPN, we have to do reticulin as well as collagen for trichrome stains.
Perfect. Thank you very much. Thank you, everyone. I think if you allow me, I will present a few slides about the MENA forum. As I mentioned, today is the last MENA forum, and I encourage everyone to follow the Saudi Society of Blood Disorder in our channels in YouTube, and all the lecture and very important education material will be there also in Twitter. And we have also in Twitter another channel that is also giving you a good educational materials. I will share some analytics for this webinars. So 8 webinars, and as of end of February, total participant was 13,180. There was 32 speakers and moderator, and 34 total country and from participants from 34 country. And I encourage everyone to. I want first to thank our platinum sponsor Janssen and the gold sponsor Hikma with unrestricted support. And also I encourage everyone to attend tomorrow webinar, which will be in multiple myeloma care in Saudi Arabia. This will be at 8 p.m. same time. 8 p.m. in Kingdom of Saudi Arabia time. At the end, I want to thank our speakers for giving us these talks today, and I want to thank all the 3,400 participants. Hope to see you in the future meetings, and please stay safe. Thank you.
Thank you
very much.
Thank you.
Everybody.
Goodbye.
Thank you.